So here you see modified uvulopalatopharyngoplasty in a 23-year-old male with a body mass index of 24 and a AHI of only 23. So everything is in the range of 23 and 24. Now he's got adenoids, he's got large tonsils, he's got some lingual tonsils, some nasal septal deviation, and we are doing a multi-level surgery. So while performing uvulopalatopharyngoplasty, when I touch the soft palate and see where it goes on the dice, it's almost a concentric collapse, both lateral as well as AP. So when I touch the soft palate to the posterior pharyngeal wall, you can see it goes and touches right above the line joining anterior pillar to anterior pillar. So I remove the uvula, the base of the uvula, in the line joining anterior pillar to anterior pillar. So that's the line joining anterior pillar to anterior pillar. When I'm doing this, I'm very sure that it will not have any effect on the speech and swallowing. If I do not go very high, it will not have any effect on the speech and swallowing. And you can see the contraction of the musculus uvuli. That's the musculus uvuli. So I am removing the soft palate in the midline. That's the musculus uvuli already divided. Now, if I want to preserve the mucosa on the other side, I can preserve it, but there's no point trying to preserve the mucosa too much there, because then we'll have to suture it upside down. And if we leave it like this, there's not too much of raw area created. Now we go for tonsillectomy. That's the anterior pillar, that's the posterior pillar. So since I need to suture the posterior pillar laterally, I am just removing this uvula here, because I'll suture the posterior pillar laterally. So I am removing the uvula completely, and that's the uvula removed. Now we go for tonsillectomy on the right side. So if you see, this is the tonsil, large tonsil on the right. That's the tonsil. So this is the upper pole of the tonsil. I pull it out, and you can see this is the extent of the tonsil. So we'll have to take an incision onto the anterior pillar. This is the anterior pillar. And you can see the tonsils coming out. Now I'll take a lux forceps, pull the tonsil medially. That's the tonsil. This is the anterior pillar of the tonsil. So I want to go lateral to the tonsil. So that's the superior pole of the tonsil coming out. I'll try to preserve the muscles as much as possible in the tonsillar fossa while removing the tonsils completely. But at the lower end, at the lower pole where I reach the tonsillar artery, I'll be careful not to expose the tonsillar artery so as to eliminate the chance of a secondary bleeding or reduce the chance of a secondary bleeding. You can see the paratonsillar vein which I am coagulating now. Now You can see how large the tonsil is, but this is still not the lower pole. Lower pole is here. This is still a cartilage of tonsil. Now I am going to reach the lower pole. And since the tonsillar artery comes at the lower pole, and I do not want to really expose the tonsillar artery, I'll turn intracapsular over here, because lower pole of the tonsil does not contribute to obstructive sleep apnea. I'm going intracapsular. You can see it. That's the intracapsular dissection of the lower pole of the tonsil, which will make sure that the tonsil does not bleed later. So this is the lower pole of the tonsil. This is the lower pole of the tonsil. I'm going intracapsular over here, and will coagulate the whole lower pole, so that this is the tonsillar artery. So I am coagulating the whole tonsillar artery and going intracapsular in this part, so that the main tonsillar artery trunk is not opened and left to bleed later on. Okay, I'm coagulating along the length, so that the pressure in the tonsillar artery never reaches the point where it can bleed. So this is the large tonsil dissected out. That's the posterior pillar. Okay, so that's the tonsillectomy over. So you can see how large the tonsil was. Now we come to the division of the palatopharyngeus muscle in the tooth fossa. Now you see, this is the palatopharyngeus muscle, and this is the oblique part of the palatopharyngeus muscle. These are the vertical fibers. So the oblique muscles of the palatopharyngeus, they are responsible for obstructive sleep apnea in the AP dimension. So this is the treatment for AP collapse. You can see this is the lateral pharyngeal wall. So I am reaching the lateral pharyngeal wall. I am not damaging the mucosa over here. I am only cutting through the, okay, and then I'll take it laterally. So the AP collapse which was happening like this, and the lateral collapse which are happening like this part I'll take care of with the barbed suture. Give me the barbed suture. So the barbed suture that I'm going to use, I'll show you that, is V-lock. So this is the barbed suture from Covidian V-lock 180 302 metric. That's the barbed suture. Now the advantage of using a barbed suture is that you do not have to take knots. So what is the principle? I'll use the barbed suture in my own technique of surgery. It's called suspension bridge technique. So the idea of this technique is that this is the pterygomandibular raphe between the mandible and the pterygoid tubercle. This is the pterygomandibular raphe. So when I take this barbed suture from the pterygomandibular raphe inside the tonsillar pillar, now this is the point which is anterior and lateral. So this will pull the whole soft palate anteriorly and laterally. So the posterior pillar or the palatopharyngeus muscle, you can see I am taking the whole bulk of the palatopharyngeus muscle into this barbed suture. Okay. The moment you take the whole barbed suture into this palatopharyngeus muscle, I like to take a little bulk of this whole thing. Now, when I pull this suture and leave it, you can see that the whole muscle is pulled laterally and it remains like that. I'll possibly just take once more to take the whole bulk, but then you go in from the same point because you do not want the suture to be exposed. So I take this and lock it, and then from there you come back to the same point of pterygomandibular raphe as you went in from. So this is the treatment for your lateral collapse. Now that lateral collapse will not happen because it will keep it pulled medially. Now the second thing the suspension bridge technique has to offer, it will keep our soft palate pulled anteriorly. So from the same point I come again and along the free border of the soft palate, almost along the free border of the soft palate, we come out. Now what this will do, it will not let the soft palate fall posteriorly. So I take another bite. This will not let the whole soft palate fall posteriorly. Okay. Now I have to go to the other side. So the work on the right side is over. You can see that it's both anterior and lateral pull is happening. So give me a second. I will stop here. Thank you for watching part 1. I'll come back to you for part 2 when I shift on the other side. Thank you.